Thanks, Carlos. I like to walk around when I talk. So, hopefully this will work. I am going to cover several areas. I'm going to spend a little bit of time on statistics, maybe a little more than I should, because this problem is, to me, is just beyond comprehension as to how bad this is, especially in this area along Appalachia. I'm going to get into a little bit about why we got into this problem, and then I'm going to get into the problems with taking care of these patients, and then I'm actually going to finish up with our study that was the oral presentation on this whole process of whether or not we should detox pregnant women during their pregnancy from opiates. So without further ado, there's a lot of drugs that people can abuse. The one I'm going to focus on is obviously opiates. The definitions is that an addict is someone who habitually or obsessively uses the drug. The drug must be taken to avoid withdrawal. And tolerance means that higher and higher doses are needed to reach that effect, and opiates has all of these. So getting into the statistics, in 1999, the #1 cause of death outside of diseases was motor vehicle accidents. Drugs was #4. And in 8 years, it's now become #2. And you're going to see it's actually the highest cause for female deaths, non-related to medicine. In the last 10 years, some East Tennessee statistics, though I know we have some people from Georgia, have been, in the last 10 years, 500 people have died just in Knox County alone. In the state of Tennessee, 1 death every other day from opiates. The death toll in Tennessee in the past 10 years from illicit drugs, primarily opiates, exceeds that of fire and homicide, as well as all of those in the Afghan war, just in this state alone. In 2010, there were 15,000 drug overdose deaths in women in the United States. So this is just focusing on women. About 10 per 100,000. The deaths from overdose in women actually exceeds deaths from motor vehicle accidents since 2007, whereas in men, more men die from motor vehicle accidents than they do from drug overdose. Almost 1 million emergency room visits alone by women in 2010. Of those 15,000 deaths, 6,000 were involved opiate prescription medications, not heroin or methadone, but the opiates like oxycodone and hydrocodone. In 1999, there was only 5,500 overdoses, so this tripled, but the number of deaths from opiates went up 5-fold. Of those 6,000 deaths, 5,000 were unintentional, whereas 820 were suicide, 658 they couldn't tell. But most of the time, the women who were dying were not planning on dying, they just took too much. Of the 1 million visits to the ER in that year, 80% were women of childbearing age. In 2010, those 6,000 deaths works out to 4 per 100,000, which was 4 times the death rate from cocaine and heroin combined. And this one is the one that is staggering to me. In 2010, there were enough opioid pain reliever prescriptions sold in the United States to medicate every single adult with 5 milligrams of hydrocodone every 4 hours for a month. Tremendous amount of this. Every drug company that sells opiates is so far in the black, it's not even, they are the most profitable pharmaceutical companies in the nation, and the ones that sell the opiates. In 2007, prescription opioid abuse cost the insurers $72 billion. As of last year, was estimated to be more than $100 billion. In 2012, 1 in 95 people were using prescription opiate medications in the United States. And that includes children. That's the whole population. In 2012, 82 opiate pain medication prescriptions per 100 persons were written. Alabama beat Tennessee again. They're #1 at 142.9. We're 142.8. We came in close. We tried hard. West Virginia is #3, but as you can see, the South is the worst at 93.7, whereas the West is the lowest. When you look at Medicaid prescriptions of 1.1 million pregnancies of Medicaid through that 7-year period, 1 out of 5 people in the Medicaid program who was pregnant filled an opiate prescription. The rate went from 18% to 22% in that time period. Again, the South was number one. When you look at NAS discharge data, maternal opioid use went up from 1.1 per thousand births to 5.6 in 1,000 births. NAS also increased as would be expected. And as of 2009, the average cost for treating an NAS baby is $53,000. I'll give you some costs at the end more recently regarding Tennessee's issue. Heroin is also on the rise, but not in the South. Our problem here is still primarily opiate prescription medications, as well as methadone and Subutex, which is available on the street. But again, it really hasn't changed that much in the South. So why does this exist? It's always easy to blame the government for our problems, but in this particular case, it actually is the government. There was one senator and two congressmen in 1999 who did not believe that physicians were managing chronic pain in the healthcare community well enough, passed a law called Public Law 106-386 that took on October 28th of 2000. It took place January 1st of 2010 and went for 10 years. It was a decade of pain. Like in California when I was there, even though I was in maternal fetal medicine, I had to do 12 hours of CME on how to manage chronic pain in patients, even though we don't deal with that per se. With that, over 3,000 pain clinics have opened up in the United States. Most of them deal with cash. Most of them are giving out Subutex or methadone. The physicians that run these places are making in excess of $1 million a year. And so it's a major problem. I don't know how to fix that, actually. And the problem is how do you measure true pain? A patient can't walk in the door and you put a meter on their head and go, yep, you're an 8 out of 10, so here's some Percocet. Nope, you're a 1 out of 10, you're kind of ripping me off, and so you don't need it. They come in, they're very good at faking pain, they get the prescriptions, they go out on the street and they sell them. This stuff is just available anywhere. And we don't have checks and balances right now. And when you look at these things, they're very powerful. If you count morphine, 1 milligram of morphine as your baseline, hydrocodone is about 60% that strength, 6/10. But oxycodone, Percocet, is 1.5 times stronger. So 1 milligram of oxycodone is equal to 1.5 of morphine. Opana, which is the one that we're really seeing a big problem in East Tennessee, and I'll talk a little bit about it in a minute, is oxymorphone is 7 times stronger. Methadone is 4 to 5 times stronger. Heroin is 2 to 3 times, but buprenorphine or Subutex is 40 times stronger. So you have a patient on 8 milligrams of Subutex, that's 240 milligram worth of morphine. And we have several clinics that will put them on 24 milligrams of Subutex. That's 960 milligram morphine equivalents. These are huge, huge doses. Hydrocodone is the second most common one abused. Vikes and Hydros, it comes as Vicodin, Lortab, Lorcet. Oxycodone is the most common one abused, which a lot of them are crushed, but some of them now have a gel coating thing that burns their nostrils if they try to inhale it. But they're still available as Oxys and O's and Hillbilly Heroin and Roxys and Blues. They all have their names, but the ones that we write prescriptions for, these three here end in CET have acetaminophen with them, Percodan, Endodan, and Roxaprin have aspirin with them. Those are the prescription ones, and these are widely available on the street as well. Oxymorphone, Opana, it's called Stop Signs, Mrs. O, Octagons. Fentanyl, believe it or not, is available on the street. It's 100 times more powerful than morphine. Methadone has a half-life of about 24 hours on average, and so you have to watch your child that's born of methadone for at least 3 days to know if it's going through abuse, if it's going to go through NAS, I mean. Buprenorphine is even longer, and you really have to watch these kids 4 to 5 days to make sure that you're going to verify whether or not the child's going to have NAS. And so you'll sometimes see that they talk about less neonatal abstinence syndrome. When we watch the kids at UT up to 4 to 5 days, I don't think there's a big difference between them. You just have to watch the kids. And the other problem that's occurring in East Tennessee is there's a few more infant deaths, and they're coming in this population. And I think what's happening is they're being discharged, and then the child goes through NAS when they get home, and then there's deaths from shaking the child because it's an irritable kid and it's hard to take care of. And so we have to make sure we watch these babies long enough if the mom was on Subutex to know if there's an issue. The signs and symptoms, we all know about the abdominal pain, cramps, tachycardia, high blood pressure, muscle aches, nausea and vomiting. But other ones people forget about is thirstiness, runny nose, runny eyes, and yawning. So anybody yawning out here, we have to do a drug screen on you before you leave. It affects all parts of the body, and in most cases it slows things down. It slows the brain down, it decreases pain, it slows heart rate, lowers blood pressure, decreases respiratory rate, usually slows the GI tract down so you have constipation, but there are a few patients who have a paradoxical response to it and they have diarrhea. I actually think we see increased amniotic fluid in these patients because the babies swallow less and possibly breathe less, but in some of the data that I'm collecting prospectively, we have a lot of AFIs that are high normal or even mild polyhydramnios in the 20s. And so it's something to be aware of with that. Do they cause birth anomalies? There's not a single paper that's really proven that other than Broussard, which was in the Gray Journal in 2011, that talked about a slight increased risk of some cardiac defects not seen in any other study. They are listed as category C, so most of the addiction pain clinics and stuff say that they're not really harmful to take in pregnancy other than the addiction aspect. But I don't really think from all the data that I've read that they're truly a teratogen, but it's something that I don't know if has been fully answered yet. As far as prenatal care is concerned, again, most of them have little or no prenatal care. They're often unemployed. They have horrible histories of physical abuse, sexual abuse, emotional abuse. They have low self-esteem. The reliability of their history is low, as you all know, in taking care of any of these patients who are addicted to opiates. They often use more than one drug, which also makes studies difficult. I would estimate that 40% of our opiate patients are also on a benzodiazepine. Usually Klonopin is the other one, or Xanax. The purity of the street drug varies, which is one of the arguments of getting them into a program, because then you at least know that methadone and Subutex is pure, at least it's been given to them. Because a lot of times heroin and those things will be cut with anything from crushed aspirin to talcum powder or anything to increase the volume of the white material, and that's what leads to all the other issues that these patients have from injecting heroin and stuff. Complications from an obstetrical standpoint, there's a higher, in the drug abuse population, a higher rate of premature rupture of the membranes, higher rate of preterm labor, IUGR, which I'm going to come back to in a minute because I think it's a little bit different than any other IUGR we've seen. Increased risk of stillbirth, sexually transmitted diseases, especially hepatitis C in our population, and I'll briefly touch on that at the end. A higher cesarean section rate. Placental abruption is higher, but abruptions are primarily with cocaine and the amphetamines. There is a thing called speedball, which is a morphine and cocaine or heroin and cocaine, and a lot of drug addicts will use that. And it's the cocaine and the amphetamines that lead to the placental abruption. Drugs can affect the heart rate. The opiates are going to flatten it out, make it non-reactive, decrease the variability, will not produce D cells. So if you're seeing decelerations, then that's something related to something else. And then the neonatal withdrawal patterns will vary. Oftentimes they're just more delayed if it's methadone and buprenorphine, just because of their longer half-life. Now, IUGR has always been listed as a complication of opiate babies, of babies born of mothers who are using opiates. And IUGR is either symmetric or asymmetric, the way we talk about it in obstetrics. Symmetric means it's the fetus, so that the head and the abdomen and the femur and the humerus are all symmetrically 2, 3, 4 weeks behind, whatever. Asymmetric IUGR is placental induced. That's where the bones are usually spared. So your head circumference, BPD, and femur length and humerus length are going to be closer to the dates, and the abdomen is 3 or 4 or 5 weeks behind because of placental function and how much nutrients and stuff it's giving to the baby. Well, when we were looking at this, because it's frankly rampant, I would bet 1 out of 5 of our high-risk patients out of, like several thousand we see are on opiates. It was different. The abdomens matched the dates. It was the bones that were small. So we did a retrospective study that was published last year in the American Journal of Perinatology, the largest study so far on this, and we had 332 babies diagnosed with NAS. Now 89% of them were polysubstance abusers, so I can't say it's necessarily the opiates. For all I know, it's the combination of everything, especially the benzodiazepines. But we found a statistically higher rate of smaller head circumference and femur length. And no opiate was particularly at cause, but when you look at the data between the subjects and the controls, a head circumference less than the 10th, between the 10th and the 3rd, and less than the 3rd was highly significant as being smaller. And so I was actually working with a fellow in Cincinnati working on seeing whether we could get someone to evaluate osteoblast division rate and exposing these osteoblasts. Osteoblast is the cell that produces bone. Whether their division rate goes down in the presence of opiates or a combination of opiates and benzodiazepines, and whether or not that would catch up if the opiates were removed. And so I have some prospective study going on right now to see if we verify what we found retrospectively. And in our area, as you can see, oxycodone is number 1. Believe it or not, Subutex off the street's number 2. Hydrocodone's number 3. Whereas heroin, we only had 3 cases. So a very small number of heroin, at least so far. Oxymorphone, something you need to be aware of. This is bad stuff. It will produce thrombotic thrombocytopenia purpura, which is a very horrible disease that has a very high mortality rate. Complicated to explain to you what it is, but affects the entire body. And this comes from patients who are using Opana IV. So when we get those, we really try to get them off of that as soon as possible. We've had 2 cases of maternal deaths, one in Knoxville and one in the Tri-City area. So it's a bad problem. Now, prenatal care, obviously it's a team approach. The obstetrician, pediatrician, social services, drug dependency center. We need to try to get as good as dating as you can get, frequent visits, serial ultrasounds, antenatal testing in the 3rd trimester, and then discuss delivery at an appropriate center. In our state, we have to discuss the state law because there's a law that if a woman delivers a baby that has, and the child has, or the newborn has issues related to opiates and the mother was not getting the opiates from a program or a prescription, she's at risk for being arrested for a misdemeanor. Been very controversial, but I will tell you I've had a lot of patients come to our clinic because of that law worried about this process, and so I don't know 100% whether it's totally bad, but very controversial in our state. Now, to get to the meat of this, withdrawing a patient from opiates has never been recommended, concern over a higher rate of intrauterine fetal demise. And so we've always recommended putting these patients in drug maintenance programs, which is what I taught residents and medical students and nursing students for years, until I really kind of analyzed this based on the fact that I had a lot of patients who would come in and say, look, I didn't plan on getting pregnant. I am now pregnant. I want to continue the pregnancy, but I want to be off these drugs. So I actually went to the literature to get all the data to show how horrible it is to detox, to give it to the patients so we would just leave them in a methadone maintenance program. And what I found was rather disturbing but not unexpected. As Carlos was saying, I always tell my residents, if you want to find a research project, go to the most recent ACOG technical bulletin, read it. If you find something that doesn't make sense that's not referenced, there's your research project. There are so many things put into those bulletins based on the opinion of the person who wrote them that isn't based on research, that's where you can get your research ideas. So anyway, I dug into this and found out that it's all predicated on 2 patients. We have not been recommending opiate detoxification in pregnancy for 40 years because of 2 case reports. First one was by Rementary and Nunag, a case report of a mom who came in at 39 weeks with a stillbirth who went through withdrawal a few days prior to that. And he basically wrote down that the baby died because the mother went through withdrawal a few days before. And then that paper actually summarizes the preceding 10 years of the bad outcomes in the opiate-addicted heroin population and how there was higher rates of stillbirth. And the thought was that these women, if they can't get the drug, are going through withdrawals and there's highs and lows and all of this. And so this whole population is bad. And this causes the baby to die, so I would recommend that you get him into a maintenance program. The second paper was by Fred Zuspan, who's the chair at Ohio State. Actually, he and Ted Quilligan and Eastman were the ones that actually were kind of the pioneers of creating maternal fetal medicine. Ted and Fred were the ones asked by the board to create the Division of Maternal Fetal Medicine when they were both at Case Western. And Fred's a very, very brilliant man, knew him. He passed away a few years ago. Ted is still alive, actually. He just had his 90th birthday. He did an interesting study, when you didn't have IRBs. He had a pregnant woman that came in. She wanted to go through withdrawal. They kept her in the hospital, and he did serial amniocentesis procedures on her as she was going through withdrawal and found that the epinephrine and norepinephrine levels in the amniotic fluid went up. And he said, the baby is being stressed. We must stop this. They stopped it, maintained her on methadone. She delivered a term. Baby was fine, though it did go through NAS. But because of that and Rementarians, he said, again, I don't really think we should detox women in pregnancy because it looks like it's harmful. And then it just propagated from there to the point where that's what the standard of care has been. So since the 1970s, don't withdraw because it's going to potentially stress your baby and kill it, and so don't do it, based on 2 patients. Well, the first one who broke this chain was Moss in 1990, published in the Journal of Perinatal Medicine, of 57 mothers that were detoxed with methadone inpatient over 7 years. They only had a 30% success rate, but there were 2 cases of NAS in that group. 70% were not successful, but he had no fetal deaths and no adverse outcomes from the process. 8 years later, Jody Dash, who was a fellow and taking her, I actually got to meet her at SFMM. She said when this was done, she was a fellow at Texas and had 34 mothers detoxed over 7 years, inpatient, detoxed over 10 to 20 days. They had about a 60% success rate, 3 cases of NAS. Again, no fetal deaths, no fetal distress, no problems related to this. That was in the Green Journal. Then in 2003, Ludi had, in the Journal of Substance Abuse Treatment, 101 mothers over 12 years with inpatient methadone detox. There was 1 miscarriage and 5 patients detoxed in the first trimester, but no losses in the second or third trimester. It didn't give any information as to how many they succeeded in and how many NAS cases there were. Jones is the other article. This is the 4th one on detox, but as the other article that people use to argue against detox. Basically, at 175 patients, 95 went through an inpatient, very rapid methadone withdrawal. They got them off of drugs within either 3 days or 7 days. The relapse rate was 54%, and the rate of NAS in this group was 28%. There were 80 that were maintained on methadone. The interesting thing about this paper is that they say the rate of NAS in that methadone maintained group is only 24%. I've never seen that in any other methadone program I've seen. The NAS rate in methadone programs, and every other program I've ever seen, is 60% or higher, if not 80 to 90, if you watch the child long enough. But no losses or preterm labor, any problems, but the women this 80 women had more prenatal visits than this group, and so their conclusion was methadone maintenance is better because they had better prenatal care visits. And then finally, Stewart, who was out of Southwestern, same place Jody Dash was at, 95 patients over 6 years, about a 60%, 55% success rate. The NAS rate in that group is 10%, 80% rate of NAS in the 42 that were not successful in detox, but again, no fetal deaths or fetal distress during the process. So you have these 5 studies published in 5 different journals over a period of 20 years, kind of hodgepodge, and no one really is paying attention to this because the standard of care for 40 years has been don't detox these women. In fact, a recent meeting held in Atlanta in 2012 from 11 authors from these states basically came back and actually looked at this data and kind of said, well, maybe it's not harmful, but because the relapse rate is so high, we still don't recommend doing it. So we did a study. This was the oral presentation. Our purpose was to see if detox is harmful, because every single pregnant patient would come to our office going, I'm in this methadone program or in this Subutex program, and the physician who runs it will not detox me because he says I'm going to kill my baby. And we're like, time out, let's see if that's the case. So we analyzed it mainly for safety. Because this was not a randomized study, we were just looking at safety, but we had 4 different types of patients who were being detoxed. We were able to look to see if there was a difference between the way they were detoxed and what we found out. So there was a secondary aspect of the study. So it was retrospective data, but we collected it prospectively. We were collecting these patients in the different ways that they were detoxed, but at the very end we put it all together for a study. All women were delivered by our group at the medical center in Knoxville. We had 4 groups. We had really 3 groups, but the middle group was split into 2. The first group was those women who are incarcerated, I should say patients, not patinted. But we had women that were arrested for selling opiates, but them themselves were addicted. They were selling to maintain their habit. And they were incarcerated, and the system in Knoxville is that they cannot give opiates in the jail. So these women acutely detox. They get Lomotil for diarrhea, Phenergan for nausea, clonidine to help with some of the symptoms. But otherwise, it's a cold turkey detox. Group 2, we have an inpatient, it's kind of a small center by itself, but it's an inpatient detox place in Knoxville. And they detox them over a period of about 5 to 10 days with Subutex. And then if they can, they do their best to get them into this long-term behavioral health program that is funded by charity in the city of Knoxville. But if they can't, they get sent back to their routine prenatal care. So we split those into those who had inpatient detox and intense behavioral health follow-up, which is really a halfway house. These women go to a home, they can bring their other children, there's a house mother, and they're there every day, you know, and maintaining and trying to stay off of the opiates. And then group 4 was our slow outpatient buprenorphine. We had about 3 Subutex places in town that agreed to detox people slowly over a period of 8 to 12 weeks. And so, and then there's a program that tries to follow them very, you know, almost daily as a behavioral health process after they get discharged, after they get off of the Subutex. Now, NAS is reportable in the state of Tennessee, and there's definitions based on Finnegan scores, which is a scoring system of what the child looks like in order to be given the diagnosis. So everything is standardized, but they need to be watched for 3 to 5 days, depending on which drug they were on. We did all of the regular collection. We didn't really have any exceptions. A lot of people wanted to know if we excluded anybody, but we didn't exclude anybody because we weren't randomizing them or putting them into the various aspects of the study. Again, our primary thing is, did we kill any babies or cause major problems by the detox? And was there a difference in the rate of NAS in these children born based on the 4 different groups? So we had 301 patients. This study was as large as the other 5 combined. And we had 28 patients detoxed in the first trimester. No losses or problems related to that. There were 2 losses in this group. One occurred 8 weeks after she was detoxed from a placental abruption. She was still incarcerated. She was not hypertensive. Her drug screen was negative, so we don't know what caused that. And the second one was fully detoxed at 12 weeks and came in with a hydropic fetus at 34 weeks, but she refused autopsy. But again, neither of these losses were related to the detox because they had already been off for 2 to 5 months. We had 148 in the second trimester, no losses. 125 in the third trimester, no losses. There were no cases of preterm labor or premature rupture membranes related to the process. And when you look at the groups of 108 jailed patient, we had a rate of NAS of 18.5%. If they were detoxed inpatient and put into these halfway houses, their NAS rate was this. And if they were slow outpatient detox with the continued behavioral health, the rate was only 17%. If they were detoxed as an inpatient, patted on the fanny and sent back to their routine prenatal care, we had a 70% rate, which matches the other studies. So basically what we found was if you detox them and you get them into a behavioral health program, you can lower your NAS rate. They're going to get NAS. We had 4 out of 23 moms living in this home that somehow got back on the drugs and delivered babies that went through NAS. Substance abusers who want to use it are going to get it, but you can at least lower it from 100% to say 15 or 20% based on this behavioral health. And if you exclude group 1 because they're incarcerated, and that's not going to happen in medicine, I don't think, but you take group 2 and 4, which were the ones who were detoxed and put into a behavioral health program, and compare those to the ones that were not, the difference is highly significant at p less than 0.0001. So if you look at the preterm delivery rate, it was a little high at 17%, but over half of these were inductions for IUGR. And the other interesting thing is only half of them were really IUGR because their bellies are normal size, and so at the time they're born, their birth weights are okay. What made them IUGR was the small head circumference and small femur length. And so it gets back to the IUGR with opiates is more bone related than placental. It's not placental, actually. So with this study and the other 5 combined, we have over 600 cases of patients who are addicted to opiates that were withdrawn without a fetal loss to this. So we need to get rid of this business that detoxing a pregnant woman is harmful to the baby. Now, I don't know whether we can do this. That's the second line of thing that Carlos kind of mentioned. Again, you got to remember that the stillbirth rate in the low-risk population, you take 1,000 healthy women with no medical problems and no nothing, the stillbirth rate's 4 per 1,000. The reason we don't do antenatal testing on all pregnant women is because of the extra intervention and issues that go on from routine antenatal testing. So we only test the high-risk population. The stillbirth rate in our high-risk population in the United States, if they have good prenatal care with antenatal testing, is lower than the stillbirth rate in your low-risk population. Now, the average cost of NAS in Tennessee in 2014 is $65,000 per baby. With 1,000 NAS cases, we have a cost of $65 million a year just on 1,000 babies in our state alone. If you cut this in half, cut this in 3/4, look at the amount of money you're going to save. If we cut it in 3/4, we save the state $50 million a year on this problem. So when you look at this process, I've been working with the state government people to try to get them to understand that, and I'm hoping Tennessee and other states will be pioneers in this, is that everything is in its cost center. You have cost centers for peds and cost centers for women's health and cancer and geriatrics and cardiovascular diseases. We need to carve out a different cost center, and that cost center is maternal care and newborn care. We pull the newborn out of the peds and we pull the maternal out of women's, and that's your cost center, because anything you do to the mom affects the baby. If you do something really good with the mom and you have less and NICU admissions, you're saving a ton of money. Because the state realizes this now, that if I can get rid of NAS or lower it by 75%, I'm saving them $50 million. But I said, but the only way that's going to work is if you put $10 million of that $50 million on the maternal side to create these behavioral health programs that can stay on top of these women once they're detoxed. Otherwise, you're going to go back to a 70% relapse rate, and it's going to be a waste of time. So you have to, and so they understand that they got to put more on the maternal side, but the way they pay for the mother's side is saving it from the newborn side. But you got to pull them out of pediatrics and women's health, or they can't see that. They play numbers games. So we actually recommend that these women actually get detoxed if we can. You know, if a woman does not want to get detoxed, you can't force her to go into these programs. So you just maintain them. That's the option. But what we need is more funding for research. I still have about 6 or 7 projects ongoing. We need more access to programs that are willing to withdraw women, and hopefully when this gets published, there'll be some edicts that these pain clinics can actually detox and quit telling people it's going to kill the baby. We need better long-term psychosocial behavioral health programs. You know, ultimately, it would be nice to fix the pain clinic problem and get rid of all of these clinics that have shown up that pass this stuff out like candy, but that's a lot harder. And with that, I'll end.